Hello, good afternoon. It's a pleasure to chair this symposium with the theme of past, present, and future of treatment for bipolar disorders. We have four distinguished speakers, and we will start with the first speaker, who is Professor Kostas Fountoulakis from Greece, Professor of Psychiatry in the third department of psychiatry in Aristotle University of Thessaloniki, focal point in WHO, and Zone 8 representative of APA. Professor Fountoulakis.
Thank you, Professor Yakogiannis. Good afternoon, everybody. This is maybe the central symposium of the current Congress, and I'm going to present the hard data, what we really know about lithium, what are the limitations of our knowledge, and what are the exact, based on hard data, the exact indications and contraindications for the use of lithium in bipolar disorder. First of all, let's get to know with lithium. Lithium is an alkali discovered by Jakob Berzelius, who named it lithium after the Greek name, the Greek word for the stone, which is lithos. And in the late 19th century, its therapeutic properties were discovered by the Lange brothers, who used it to treat depression. But their endeavors were not fruitful, and knowledge of the therapeutic properties of this element were largely forgotten for many years. However, lithium was very popular as an add-on in beverages because it could produce foam. So it was used to for lithia beer, and also as a remedy because solutions of lithium could dissolve gallstones. So it was widely consumed by the population, which resulted in some toxicity cases, and it was completely banned eventually and largely forgotten. You can see that the original version of 7-Up was lithiated lemon soda. It was not until the end of the Second World War when John Cade discovered again the therapeutic properties of lithium. Probably it was erroneously he considered some toxic sedation side effects of lithium to be therapeutic. He didn't have the ability to measure plasma levels. However, he reported the first therapeutic effect on manic patients, had the first death because of lithium toxemia, and it took several decades until Mogens Schou would re-establish lithium as a therapeutic option, and Paul Christian Baastrup would finally search its maintenance properties. A key role in the establishment of lithium as a therapeutic option was a new type of spectrophosphamatometer, which made lithium levels determination much more precise and in a much more easy way. So in this way, we were able now to avoid toxic levels and the lethal consequences. We know that the established therapeutic dosages between 0.6, 0.8 by 1.5 for the acute phase, usually 3 to 4 capsules of lithium orally, and the maintenance levels are a little bit lower. There is a very specific way these levels are determined. It's rapidly and completely absorbed with serum concentrations achieving peak within 1.5 hours approximately. It's not binding by any proteins. There are no metabolites, of course. It's not a molecule. It's not a large molecule that will break itself. It's excreted by the kidneys almost exclusively, which means that kidney function is essential. And creatinine clearance is also a marker of this function. It has an elimination life depending on the formulation of 18 to 24 hours. And as said, the most reliable marker for kidney function and lithium clearance is creatinine clearance. It is associated with a number of adverse events. We know that: neurological, endocrinological, cardiovascular, renal, gastrointestinal, hematological, dermatological, and the general like weight gain and fluid retention. We see many of them. We see many of these adverse events, especially under long-term lithium treatment. But we do not see the more lethal and more dangerous adverse events so frequently, because patients that today receive lithium are rather the most collaborative part of patients, and they are under very frequent monitoring. So I'm going to present data mainly from the last paper you see at the right, which I co-authored with Mauricio, Tohen, and Carlos Zarate. We scanned all the literature, and we found all the hard data concerning the use and usefulness of lithium. We started with 874 papers plus 65 we fished from other sources. According to the PRISMA method, which is a very precise method to scan the literature. And then we subsequently, at subsequent steps, we classified papers into various domains and questions. So for acute mania, we identified 64 papers, 64 papers, I would say. All monotherapy are positive. They consider lithium to be the first choice in the treatment of acutely manic patients, even in those patients which have hallucinations and psychotic thinking. So surprisingly, it seems that lithium is also efficacious against psychotic symptoms in the frame of acute mania. It's equivalent to the other so-called mood stabilizers and aripiprazole, but it seems that it has a broader effect, but it seems to be less efficacious and slower acting in comparison to antipsychotics, and we are talking about second generation antipsychotics mainly, but again has a broader effect. It acts in a broad array of symptoms and in a broad group of patients. Its combination is peculiar. I would say we can combine it with carbamazepine, quetiapine, haloperidol, lorazepam, risperidone, senapine, but not with ziprasidone, gabapentin, and some others. And most of these combinations have more adverse events in comparison to monotherapy. So lithium is not to be combined with anything else that works on acute mania, but it seems that it has preferences with specific antipsychotics and carbamazepine. Combination means that you start over with right away with the combined treatment. Add-on means that you have a patient that has received lithium, did not respond satisfactorily to lithium, and then you add something. So in patients which are refractory to lithium, you can add carbamazepine, olanzapine, quetiapine, aripiprazole, senapine, or donepezil. It's a slightly different picture in comparison to combination treatment, but it has a number of common features like the combination with atypical antipsychotics. Now, the post-hoc and the meta-analytic studies concerning the acute manic phase confirm the superiority of atypical antipsychotics confirmed that lithium is more favorable in terms of adverse events in comparison to antipsychotics and antiepileptics, and suggested that lithium might not be efficacious when depressive symptoms within the frame of an acute manic episode emerge, not in the frame of a mixed episode, but when some depressive features emerge. Now, concerning acute bipolar depression, we found 78 papers. Now, the data here are negative concerning monotherapy. Mixed and insignificant are comparison studies, while concerning combination treatment, it's not recommended to be combined with antidepressants, and it could be beneficial to add pramipexole or maybe inositol, and in refractory patients, lamotrigine, ketamine, modafinil, thyroid hormones, lurasidone, oxcarbazepine, but not again antidepressants. As you can see, both combination and add-on trials have largely insufficient and negative results, and the overall picture of lithium against acute bipolar depression is not positive. What is also the picture drawn by meta-analysis, except by one who leaves some space, but also the latest meta-analysis, which was a Cochrane meta-analysis, was negative for the usefulness of lithium against acute bipolar depression. For the maintenance treatment, we found 72 papers. What is important is that monotherapy trials were not enriched, which means that lithium was proven to be efficacious in a broad range of patients and symptoms, not enriched for previous response to lithium. In fact, some of these patients were enriched for response during the acute phase to other agents. It's equal to most other efficacious treatments and superior to some. Its combination with atypical antipsychotics is positive, but not with olanzapine and not with antidepressants, both for combination purposes as also for add-on treatment. And the overall picture here with the maintenance phase is that it is more efficacious towards the prevention of manic episodes and less efficacious in the prevention of depressive episodes. The combination with antipsychotics is beneficial, but not with antidepressants. So the overall picture for lithium is that it is more of an anti-manic, both in terms of the acute phase and the maintenance treatment, and less of an antidepressant in the frame of bipolar disorder, although an antidepressant effect and an antidepressant prophylactic effect cannot be excluded. For the treatment of mixed episodes, which are not anymore considered as entities by DSM-5, but still they exist in the literature, the combination with olanzapine was positive during the acute mixed episode, but negative with other agents. And for the maintenance treatment, the prophylactic phase, positive were the data for the combination with quetiapine. What seems to be the case here is that, okay, lithium could be useful in the treatment of mixed episodes, but in combination with olanzapine or quetiapine, not really alone. And in patients which are overtly dysphoric, its efficacy could be less intense. In the treatment of rapid cycling patients, there is a definite positive effect, which is weak. It's equal to valproate, which is surprising because we usually teach that lithium is for very classic and non-rapid cycling patients, while carbamazepine and valproate are for rapid cyclers. The data suggests it's equal to valproate in the treatment of these patients. The data are negative for the combination of lithium plus valproate, and positive for the combination to carbamazepine and quetiapine. The hypothyroidism induced by lithium is a tricky issue here, because we know that hypothyroidism could trigger rapid cycling. So it's a dark corner for lithium treatment in rapid cycling patients. It could be used somehow in the treatment of comorbid substance abuse and OCD, especially in combination with olanzapine, memantine, and aripiprazole. Some data, it is superior to quetiapine concerning neurocognitive disorder, meaning that it affects neurocognitive functions less than quetiapine, or it improves them better than quetiapine. But it's one study and a rather weak effect. And concerning fatigue in combination with ketamine, it seems that there is some kind of beneficial effect. It's not well studied in all these side-away conditions. Usually, lithium is studied in the mainstream aspects and facets of bipolar disorder. Now, with suicidality, lithium is some kind of a legendary agent. It is considered to be to exert a protective anti-suicidal effect, but in fact, no controlled studies exist. There is only one post-hoc analysis which suggests that combination therapy with olanzapine plus lithium versus lithium alone reduced the score, which does not give credits to lithium. And a meta-analysis produced unconvincing results. If you see the charts closely, you can see that it does not differ from placebo, and it is equal to other agents. Now, if you pull all the data together, it gives some kind of a positive meta-analytic result, but this means at best, if there is any anti-suicidal effect, this is very, 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 very weak. In the frame of the CIMP work group, which myself and Mauricio Tohen took part a few years ago, we tried, among other things, to see how lithium performs in and how we should position it within this guideline. You can see that again we used the systematic review, the systematic PRISMA method. We rated the data into 5 levels, 4 plus a negative non-recommended level. We created extended charts to assess the true efficacy of each agent per phase and facets of bipolar disorder. And here you can see the comparison of each agent, and you can see in the red color lithium across the CIMP, the WFSBP, the CANMAT, the NICE, and the British Association of Psychopharmacology guidelines. You can see that the opinions vary from first choice to third choice. For acute mania, here are for acute bipolar disorder, from non-recommended, the WFSBP, to first line with the NICE. And here is the maintenance phase. Now for the maintenance phase, there is almost complete agreement, but the maintenance phase is maybe the easiest phase to consider. And to summarize, you can go to the App Store or the Google Drive and download this Android, and also for Apple phones, you can have the same application that will give you access, computational access. You can use this application to apply the guideline of the CIMP and see how you can treat your everyday real patients with hard scientific data. Thank you.
Thank you very much, Kostas. It was very interesting. It's always interesting to go for an overview of the data on lithium. And now we will continue with the second speaker, Jair Soares, a professor and chairman of psychiatry and behavioral sciences in University of Texas, Houston, management of treatment-resistant bipolar disorder patients. Dr. Soares.
Well, I'm honored to be part of this distinguished panel. And my focus here today will be on treating the more complicated cases of bipolar disorder. I want to start just by saying that, while we focus a lot on medications, which are very important, there is also, two other domains there are, for these more complicated patients in particular, they are super important. I mean, one is psychosocial interventions, and we're going to discuss them and talk about what might be more evidence-based. And then the third is really, a healthier lifestyle, that, things that will just, position the brain to, hopefully be healthier and last longer. So those are very important parts of, I guess, the formula for trying to help these complicated folks, or a complicated case of bipolar disorder, to achieve outcomes that are as best as they can be. I have my disclosures here. I'm involved with clinical trials in consultations, advisory boards with the companies listed there. So the first thing for us to discuss is how broadly we want to define this. The late Jair Pakisco, as we know well, proposed a broader conceptualization that would encompass the cases where the hypomania would last, just maybe a few hours or less than the 4 days that the current psychiatric classifications, DSM-5 included, require. If we define it very broadly, we may end up with a prevalence of about 5%. Defining it more narrowly, as in the DSM-5, we end up with a prevalence around 2%. And as you guys know, we clinicians know that BP2 is a hard diagnosis in many ways. It's both missed, like underutilized, but also overutilized. Primarily, as it may be confounded, anxious depression has some of the elements that people may recognize as being part of hypomania sometimes, and then you have to rely on the retrospective recollection of the patient. It's not trivial, complicated, difficult diagnosis here for sure. The course of the illness for these folks varies a lot. No patient is like the next. A lot of variability across the different phases, as we see in this diagram here. A very important point is to realize that the prevailing flavor is really depression, both BP1s and BP2s. Most of the time, when they are symptomatic, we are really, what we are seeing most often is really the depressive phase. So that's, in all likelihood, that's how they're going to come to our outpatient clinics to see us. I will save this topic for Dr. Tohen, who will give us a full presentation on it, but it's a very multidimensional illness with lots of comorbidities, both psychiatric comorbidities as well as medical comorbidities, and those are often some of the hardest to treat patients. In particular, the ones that have a lot of trauma in their history, PTSD, other anxiety disorders. The ones with a personality disorder as a comorbid condition, those are harder generally. The ones with a substance abuse, and there are many, data shows that over 50% of these patients will at some point in their lives develop a alcohol or substance use disorder. And then the ones that develop complicated medical conditions, and these patients are more prone to those. There is, quite a bit of data out there to show that. they may end up as more complex cases for us to manage, and they may end up overrepresented amongst the more chronic patients that don't seem to get well, or if they get well, they don't stay well for extended periods of time. Well, by now, there is really no doubt that we're talking about brain disorders. 3 decades of brain imaging studies with MRIs and PET scan have demonstrated that. These patients have abnormalities in frontal limbic circuits in the brain, not only functional and neurochemical, but also some subtle anatomical changes. Some of the key circuits are represented here in this diagram, orbital frontal cortex, anterior cingulate, amygdala, hippocampus. The trouble is that the changes are subtle by and large, and not really specific. So none of this is at a point that helps us diagnose or helps us best match certain patients with certain treatments. It's a little disappointing after 3 decades, but also not that different than what you will see for the genetics story about bipolar disorder. It tells us that these are very complex puzzles, and we are just scratching the surface as to in trying to understand, the specific mechanisms and causation, which is very, very needed, to guide hopefully more efficacious interventions, and also to allow earlier interventions that hopefully will lead to better outcomes for these patients. Well, very important data from the past, I guess going on a decade now, but it really shows us that significant adversity in childhood primarily leads to sustaining changes in the brain. And some of the patients with more complicated cases of schizophrenia and as well as bipolar disorder, there are studies showing that they seem to have more pronounced brain changes as well as neurocognitive changes. When people compare the ones with significant adversity in childhood, and that's generally extensive physical abuse or sexual abuse, compared to the ones who don't have that type of history. This is work here from Professor Benedetti from Italy demonstrating that. So we've talked quite a bit, in our field about this notion that there is some level of progression, unlike what Emil Kraepelin had proposed, I guess, 100 years ago. And it seems to relate to, well first, trauma exposure seems to be a big risk factor. And then chronic exposure to substances of abuse, they really do not help the healing of the brain, and they seem to make, whichever level of damage that the brain has seems to get worse over time as folks will continue to abuse substance for the ones who do that. And then data showing that the larger the number of episodes, primarily manic episodes, generally worse off these folks will be as far as, their brain health, if you measure different aspects of any different modalities of brain imaging, as well as neurocognitive testing that can be done. Quite a bit of literature to suggest that the longer this goes on, the worse it seems to get. And folks in our field have talked about a neuroprogression, not for everybody, but there's certainly a subtype of patients that seem to be more chronic. And the proposed mechanism might be some neuroinflammation that leads to damage in the brain and may kind of differentiate the patients that seem to be more chronic. Changes in oxidative stress in the brain neurons. Mitochondrial dysfunction is another area that's being talked about, as well as abnormalities in the production of neurotrophins. The search for biomarkers of this illness progression has been kind of elusive. The tools are getting better. I'm very hopeful that we will see substantial progress in this area over the next 10 years or so, but we are not there yet, clearly. The hope for more individualized treatments. We've seen other fields of medicine like oncology. The outcomes have been transformed for many types of cancers as they understood better the pathophysiology involved, and they were better able to match certain treatments with the kinds of pathway abnormalities that different subtypes of patients and different types of cancers will have. So that's the hope for psychiatry, but we are nowhere close to that yet. I mean, as we all know well. This is data from a large international collaboration. We've been part of it, and some of the others here are part of it too. This is led by colleagues at University of Southern California, Paul Thompson. They created some platforms that allow us to essentially analyze data, large data sets acquired across different sites. And what we've done here was a very sizable analysis of MRIs acquired from bipolar patients and healthy controls. And the main point that I want to illustrate here from this analysis is that the folks that have been ill for longer periods of time, they seem to have more pronounced cortical abnormalities, measured here as cortical thickness, and across different cortical areas, frontal, parietal, occipital. And lithium seemed to have some effects in preventing that, not as clear for the other medications. Some of the others seem to actually make that measure worse. It's not necessary to say that they're not going to help patients, but the point here, and those were mostly lithium responders, people who had been on lithium for a while. These folks seem to have their brain more preserved than folks who did not respond to lithium or folks who had been on many different medications. So some might be effects of lithium, but also some marker of actual treatment response to lithium, to some extent here. This is another study done by our group, published a few years ago. We had a reasonably sizable sample of patients with MDD, bipolar type 1, and schizophrenia, and also healthy controls. This is not a longitudinal study, but we had good representation across different age groups, a big age spread, as you can see in this graph. What I want to show you here is that early on, they seem to be indistinguishable, but when you go past the 4th decade of life, the schizophrenic patients in blue and the bipolar 1 patients in green, seem to be more and more different than the red, which is MDD, and the black, which is healthy controls. And those were some broad brain measures of like gyrification, like measuring the folding of the brain as a global measure of quote-unquote brain health. So essentially showing that there may be some processes happening here where primarily after the 4th decade of life, in average, the bipolars and the schizophrenics, I mean, the brain seems to have more detectable abnormalities compared to the MDDs and healthies. Obviously, this is a lot, a function of chronicity, a number of episodes. Other studies will show you. If you get MDDs that have been very severe, depressed for extended periods of time, multiple episodes, you will find a lot of brain pathology, generally more global, but also some involvement in some of those key frontal limbic regions that we had talked about in the previous slide. Then switching gears now more clearly to treatment. So the outcomes for these patients are really suboptimal. There is a lot of literature to demonstrate that. They improve symptomatically, but functionally, a large percentage of them will not, recover their previous level of function. We see that, by seeing the bipolar treatments we follow in our clinics. Professor Miklowitz and Professor Gitlin have written this interesting paper here a few years back, talking about the difficult lives of patients with bipolar disorder. And their main conclusion here is that some level of residual depression, as well as some undetectable neurocognitive impairment, those seem to be the two main factors, related to much of the chronicity that these folks exhibit over time. So giving us two clear targets, if you're trying to optimize interventions. The factors involved in treatment refractoriness. Well, we talked about some of the comorbidities, alcoholism, substance abuse. If folks are going to continue abusing substances, the medications are not going to help much. At that level, they are probably not committing to, to improving their lifestyle, to live a healthier life, give themselves, enough sleep, and more regular exercise, eating healthy things that help the body, that, we also believe help the brain. Folks who keep using substances, they're not going to do any of that. And honestly, the medications are not going to have much of a chance to help them. Neither will the psychotherapy. And anxiety disorders, primarily PTSD comorbid with bipolar disorder, those are difficult cases by and large, more chronic. ADHD is a common comorbidity. A lot of that may just have something to do with overlapping diagnostic criteria if you look at patients cross-sectionally. So very important, to take a longitudinal look to see if you are really talking about ADHD or just someone who is inattentive when they are depressed or when they are manic or hypomanic. Personality disorders, big complicating factor for bipolar and other types of mood and anxiety disorders, as we know well. Well, a big one is poor social support. If I look at my patients who do well compared to the ones who don't, the ones who do well generally have good access to treatments and no trouble to get their medications and a good social support around them compared to to the ones where through all the social determinants of poor health, they are not going to be able to make it to the clinic, stay on the medications, and life is just so stressful no matter what. Those, it's a lot harder for them, for us to get them well and to remain well. Then adherence to treatment. Early on, a lot of denial. Many of these folks will need to have a few episodes to realize that it's not going to go away. They better take, control of their lives in a way and empower themselves by committing to things that we have available that could help them if they just stay with them. And then more and more we see this neurocognitive impairment. And these patients have that. I mean, in average, many studies have shown some more pronounced, primarily, like I had told before, the more chronic patients. So this is an area, once patients are stabilized, if there is much of a neurocognitive impairment there is left, what can we do to try to improve that? That's a big question in our field. Well, treatment goals: stabilize the mood, get folks with a more regular lifestyle. That's very important, sleep included. Promote adherence to treatment, abstain from substances, alcohol, and illegal drugs. Well, maintain cognition is said and done, but if patients remain more stable and less symptomatic, that's really a good way. That will certainly facilitate that. Suicide is still a very dreaded outcome for many more of these patients than we would want, and so that's something to watch for. Obviously, if they stick with the treatment, if we have treatment teams that are very responsive, that should help. But we all know that the science of preventing suicide is not there yet. Then working with these folks on how to best manage their lives, and that's where psychosocial intervention, psychotherapy is so important. We have now a big list of approved medications for bipolar disorder, and Professor Fountoulakis discussed some of that in his presentation. For mania, many things will help, and there are several drugs that have that approval. This is actually not the latest. Lurazidone, well, it's here on the depression side. We've seen more recently also a new drug called lumateperone. So there are some newer arrivals here. And you can see that the depression phase remains more of an area of need, unmet need, as well as the maintenance, more so than mania, where most any lithium or anticonvulsants that have mood stabilizing properties, as well as not only atypical antipsychotics, but antipsychotics broadly. I mean, we know they help with mania. It's not to say that we would want to use them, because obviously once we start someone on a medication to help with the mania, you hope that there will be more evidence that it will help longer term. And that's kind of like what, the ones we tend to prefer. And then there's no discussion now that the newer generation, I guess the ones we call atypical antipsychotic, the level of side effects, primarily neurological side effects, compared to the older antipsychotic drugs, there's no comparison. So, I think our field has realized that well by now. Well, Professor Fountoulakis mentioned some of the guidelines that have been available. I mean, this is a paper from 2018, some update of the CNET, that's the Canadian group, very distinguished panel, and it's not only Canadians, I mean, it's international there too. And so what they did, they tried to look at the evidence available. So level 1 is when there is like a good meta-analysis with narrow confidence interval, or randomized double-blind controlled trials that have been replicated. Level 2, there is a meta-analysis where the confidence interval is like wider, meaning there's more variability, and just one double-blind randomized trial. And then after that, 3 and 4. So 1 and 2 is kind of like what we try to focus on here. And, this is from their abstract. This is a paper published in Bipolar Disorders like 4 years ago now. Well, essentially saying that lithium, quetiapine, divalproex, azenapine, aripiprazole, paliperidone, risperidone, cariprazine, alone or in combination recommended as first line for acute mania. And then on the depression side, quetiapine, lurazidone plus lithium or divalproex, lithium. Well, Professor Fountoulakis discussed this with us. Some effects, but not really powerful as far as like antidepressant effects. Lamotrigine, lurazidone, adjunctive lamotrigine. So that's, at that timing point, that's what they concluded after looking at the evidence. And then they say, well, obviously something that has helped in the acute phase should generally be continued for the maintenance phase. The reality, though, is that for many of these patients, we will have to resort to combinations of different things to try to, maximize their stability in control of symptoms longer time. And they conclude by saying that available data suggests that lithium, quetiapine, divalproex, lamotrigine, azenapine, aripiprazole, monotherapy or combination treatment should be considered first line for initiating or switching. Again, change it a little bit. I think there's more data, on lurazidone. There is also the new arrival on lumateperone. It's good to have a toolbox with several different medications there, because many of these folks will really need a few different ones, or it's very common that we try things that do not work, or who seem to work initially but then don't work longer term. The other important notion here, well discussed in this paper here by Dr. Joyce, it's essentially the notion that early intervention is really what we should strive for. Obviously, there is not a whole lot of prospective data to show the value of early intervention. For obvious reasons, you're not going to randomize people to no treatment versus treatment if we know there are so many treatments that work. But retrospective data, very sizable cohorts, show that, generally when the earlier we intervene, the earlier people get on treatment and stay on treatment, generally the better outcomes they will have over time. Well, switching gears a little bit to talk about psychotherapy. Obviously, psychoeducation, lots of evidence that it works. So for the Canadian group here, again, part of that paper that I was showing you, that's first line, because there is level 2 evidence. And then also level 2 evidence, CBT. CBT is really the best tested type of more structured psychotherapy in this patient population. There is the next family-focused therapy, and I will talk to you a little bit about that. And IPSRT, this is like a particular type of, cognitive behavioral therapy that focuses on social rhythm and management of one's social rhythms, as well as like interpersonal relationships. Some evidence from the Pittsburgh group showing that it helps. And for other types of psychotherapy, less evidence here, including the attempts to develop cognitive and functional remediation. I'll tell you a little bit about that. Well, this is the family-focused psychoeducation developed by Professor Miklowitz from UCLA. We will see here clearly that patients with bipolar disorder that were randomized to, this is structured, manualized treatment, psychoeducational treatment to their families, compared to the ones who just had the conventional management, conventional crisis management. The ones that got the family-focused psychotherapy, I mean, they really, they stayed well much longer, significant difference here compared to the ones that did not get it. Well, what is the latest on functional remediation? I mean, obviously, that's a very important concept, and this is a great paper here by Professor Vieta and his colleagues. So if these patients are improving symptomatically, but then their function does not improve, can we learn from other conditions where there is also a lot of disability and try to import approaches, psychosocial approaches that will help folks regain their functionality? The answer is yes, we can, and there is a particular type of functional remediation applied to bipolar disorder that, Professor Vieta's group has been trying to develop. They have like a full book and a manual to implement that, and some evidence that it makes a difference over time. I mean, I think it needs to be better replicated and extended. Then on the cognitive side, is there anything that works? This is a review that I did with some of my colleagues here in Houston, led by Dr. Sanchez, Marcel Sanchez. And what we found then, which is no different now, is that, yeah, there have been some attempts with, stimulants, and nothing really that pans out consistently, as a clear strategy to improve cognition in these folks, for the ones that have more significant cognitive impairment. And more recently, we are seeing attempts to do cognitive remediation with different types of psychotherapy, psychosocial intervention. This is a nice effort by Professor Alan Young and Professor Rebecca Strawbridge at King's College in London. They are developing a new program, computerized, to essentially try to improve cognition in these patients. The million-dollar question is, okay, so maybe you can measure certain aspects of cognition that will improve after the program, but will that remain, and will that make any difference in the patient's functionality? Because if you train someone to perform a little better on some attentional tasks, I hope that will translate into functioning better, but honestly, we don't know. So it's a field of great hope, but very little, if anything, that pans out consistently where we are ready to go and recommend to others. It's a hot research area. Well, we talked about lifestyle, a lot of data showing that regular exercise, just a better lifestyle, learning, just to minimize the effects of stress and sleep better, having the type of like a daily routine that is, less disrupted by, not sleeping and lots of stress. That is not the recipe for patients with bipolar disorder to stay well a long time. So it's really important that we work with them on changes they can achieve and sustain in their lifestyle. Well, there is a treatment, TMS, transcranial magnetic stimulation. This is approved in the US by the FDA for depression. So, I mean, if bipolars are already on different medications, we're trying the best we can with lithium, anticonvulsants, atypical antipsychotics. Sometimes we have to resort to antidepressants, supposedly we shouldn't, but the reality is that the patient isn't improving. We are already at maximum doses of different medications. They often improve, and then we have to keep our eye so that that's not going to make them, have more ups and downs and more essentially diminish their stability over time. So TMS is in that category. It's not approved for bipolar, but since it works for depression, sometimes used with success, for patients, primarily if they're not tolerating the side effects of some of the medications, and we need to add something. Well, last, I'll touch very briefly, and I know that Professor Zarate will expand on this, so I'll be brief here. A few things in the horizon that excite me that I think may pan out eventually. Well, so there is interest in seeing whether certain types of anti-inflammatory drugs may help these patients. And the notion here is that there is some level of like a neuroinflammation that develops and seems to persist over time, systemic, but also in the brain. So, this is data from Professor McIntyre's group. He found some effect. They found some effects only for the ones that had history of physical abuse, significant physical abuse. And this, the agent here was infliximab, which is like a TNF alpha antagonist. For the entire group of patients, no difference from the ones that, received bipolar depressed patients that received infliximab or placebo on top of other things that they had been receiving. We have the world's expert here with us today on ketamine and mood disorders, Professor Zarate, and he will tell us, the latest on it's used a lot for MDD. There is some evidence on the bipolar side, and we'll learn from him today, what is the latest on using that to treat bipolar depression for patients who don't respond to other things. We've seen is ketamine, essentially, I guess, a cousin of ketamine become an approved treatment in this intranasal form. This is for MDD. There is no approval for bipolar depression, and seems to work fast. The question is, how long those effects will be sustained, and it's no different than what's been worked out for ketamine. That's the same question there by and large. It seems like repeated administrations over time. There is some data, to suggest that it's by and large safe, but I don't think we have an ideal schedule for, how often and for how long. But enough efficacy data for the FDA to approve this for MDD. Well, we've seen great enthusiasm in the past few years, this resurgence of interest in the old psychedelic treatments now coupled with psychotherapies and done in properly monitored conditions and also properly designed studies. There is data coming out for MDD and psilocybin, and data in other areas as well. Not much as far as bipolar disorder yet, but that's an area that I'm hopeful, we will see some progress coming. Then another neuromodulation modality called transcranial direct current stimulation. This is with electric currency like ECT, but it's it's lesser intensity of currency that doesn't cause a seizure like ECT does. And by the way, ECT remains the best we've got for the most severe case of depression, bipolar depression included. So that's certainly still part of our toolbox, no matter whether we might like that or not. So some attempts to develop all the kinds of neuromodulation that hopefully will be effective, have fewer side effects and be easier to apply. So that's where TDCS fits. It's totally experimental at this point, some promising data. Finally, I want to tell you about this deep brain stimulation. It's implanted an electrode in the patient's brains. And we have a study here in our center. We focus on what's called the media forebrain bundle, trying to replicate Professor Schlepfer's data from Germany. And the data looks good. We have not done that to bipolars yet. It's MDD, depressed patients that had failed ECT, as well as multiple treatments. So some of that needs to be extended to bipolar depression, if it pans out nicely on MDD. For our particular target, there's more novel. The data is looking good, but we've done 16 patients, and the FDA has allowed us to do 20. So we hope to finish implanting the 20 that we are allowed to by the end of the year, and then we need a little more time to follow up the ones that have been implanted more recently. We will see. So the jury is out there. Well, in conclusion, this is a very complex type of condition. We don't really understand the mechanisms involved. There's clearly a genetic vulnerability. It's a familial disease, even though we don't understand the specific genes involved. Quite a bit of evidence for some type of progression through multiple episodes of illness. Certainly, if not in all, there's a certain subtype, that where you see that more clearly, and they become quite impaired. So we need to work to develop ways to diagnose early, and ways to do prevention, and also more efficacious treatments that will lead to improved outcomes to these patients. I mean, what we have works for many, but does not work for a sizable group of those patients. So we really need to continue to step up our game to do better for our patients and their families. Thank you so much for your attention.
Thank you very much, Dr. Soares. It was really a very interesting presentation with all those details. And we will go on the next presentation, long-acting injectable use in bipolar disorder by Mauricio Tohen, professor of and chairman of the Department of Psychiatry and Behavioral Sciences in the University of New Mexico, School of Medicine. Dr. Tohen.
Thank you, Professor. The presentation will address comorbidities in bipolar disorder, and it follows nicely after the presentation by Professor Soares. He mentioned that comorbidities have an effect in terms of response to treatment and also an outcome. So we will expand on that. These are my disclosures. I had the opportunity also to work in industry, and I can tell you they do a lot of work. It takes a lot of people to get those medications or those treatments to our patients, and of course there's lots to do. So let's start with the epidemiology in terms of the prevalence of comorbid conditions in bipolar disorders. So as you can see on the table, comorbid conditions are highly prevalent in bipolar disorder. If you look at bipolar 1 and bipolar 2, a little bit more in bipolar 2 in terms of any anxiety disorders. We're focusing on anxiety disorders right now. You could argue the vast, close to 90% of patients with bipolar 2 have a comorbid anxiety disorder, and close to 87% of those with bipolar 1 among the have an anxiety disorder. Among the specific anxiety disorder conditions, as you can see, the one that is most frequent is social phobia, followed by specific phobias. So highly prevalent in bipolar disorders, the presence of anxiety disorders. Substance use disorders also highly prevalent. This is again data from Dr. Mercangas from NIMH, and as you can see, any substance use disorder for bipolar 1, you have 60% of patients with bipolar disorder also have comorbid substance use. So that is the majority. And bipolar 2, a little less. And as you can see, drug abuse, or among any of the substance use disorders, the one that is the most frequent one is alcohol use disorders. Now, in terms of the probability of getting dependent to alcohol, and this is quite interesting because, as you can see, well, if it crosses 1, that means it's not significant, so it has to be more than 1. So having a comorbid anxiety disorder also, not surprisingly, increases the risk of having alcohol dependence. It's almost twice as much. So key, anytime you see a patient with a bipolar disorder, to get a full history, may rule out also comorbid anxiety disorder, and then if the two are present, the likelihood of alcohol dependence, as you can see, almost doubles. Now, what about marijuana? So marijuana it was just approved here in New Mexico this year, and many of the states has been approved for recreational use, except for Dr. Soares' state of Texas. It's not approved for recreational use, but certainly DC, I don't know about the European countries. So we've had patients in New Mexico who've been using marijuana, so-called medical indication. So we have to do a lot of education that the data clearly shows that, and we'll look at that in some studies, that it actually worsens the outcome. So again, when you have patient with anxiety disorder, bipolar patient, make sure that you also rule out the presence of marijuana because it can alter the course of the illness. So here you have it. It's the so-called trios, 30%, 1/3 of patients with bipolar disorder actually have bipolar and anxiety disorder and substance abuse. So when you have following again the presentation of Professor Soares, anytime you have a hard to treat patient, think of comorbid or someone who has a poor outcome, rule out comorbidities and make sure they're addressed. And actually, it does also has some effects on treatment response. Impulse control disorders is also highly prevalent in bipolar disorder. As you can see, both in bipolar 1 and 2, the majority of patients actually suffer from impulse control disorder. Also ADHD, attention deficit disorder, with you have 40%, which is of course quite high, and it becomes a challenge in terms of treatment, because of course the stimulants that are used for attention deficit disorder can contribute to relapse to mania. Actually, I was asked to be an expert witness of a case of a patient who suffered bipolar disorder and also suffered from attention deficit disorder, and he died by suicide in a very violent way. He stabbed himself a number of times. And the issue in this case is, did first question, are stimulants contraindicated in bipolar disorder? Well, there would be if the patient has taken a mood stabilizer. And even if they are taking a mood stabilizer, it can still increase the risk. So this colleague got into trouble because he did not really share that risk with his patient. So again, looking for comorbidities that can lead to poor outcome. Now this is the quartet, which again is not unusual in bipolar disorder. A quarter to a third of patients have suffer from the quartet of having a mood disorder plus anxiety disorder, ADHD, and substance use disorder. And sometimes the challenge is that treatment gets fragmented. Also, the problem is that especially the substance use disorder is treated by someone else or at a different site, and that of course complicates treatment. So if you look at comorbidities, this is bipolar disorder. So it is a minority of patients with bipolar disorder who do not suffer from a comorbid psychiatric or psychiatric or substance use disorder. As you can see, lifetime, the small amount, or even current, the most patients, the most frequent comorbid condition, very clearly seen in this Venn diagram, is substance use disorder in terms of lifetime. And in terms of current is actually anxiety disorders and substance use disorder. That trio, it's actually the most frequent. And then in current, you have anxiety disorder and ADHD. Of course, there might be some issues in terms of where patients diagnose the right way. In this study by Dr. Gao from Case Western, patients were diagnosed with the use of a structured diagnostic instrument. Now, this is from a clinical sample, the data that we saw before from Dr. Merkangas, those were population sample. And even if you look at clinical sample, it is high. This has the depressive and bipolar disorder, although it's a little lower than what you see in terms of current. But in the Merkangas data set, the study showed 60%, which is similar that you find in clinical samples. Of course, you sometimes have a bias that in clinical samples you're going to see sicker patients, and in fact that's not the case in comorbid conditions, because the data from Dr. Merkangas is population-based, and it's very similar to a clinical sample. So what effect do comorbid conditions have on mood disorders? And we'll focus on bipolar. Well, it has, as we've mentioned a number of times, negative effect. Earlier onset of bipolar disorder. And as mentioned by Professor Soares, the sooner you treat, the better the outcome. Presence of comorbid anxiety will lead to increased symptom severity. It also increases the risk of relapses, lack of response to treatment. Again, here, when you have a patient not responding to treatment, anxiety, non-treated anxiety would be certainly a risk factor. Presence of substance use disorder, higher incidence of suicide. And then patients with comorbid anxiety disorders actually get misdiagnosed, and the problem with being misdiagnosed, that leads to wrong treatment decisions. Now, what is the effect of comorbid anxiety disorders on being euthymic? So this is longest euthymic period. So as you can see, the absence of anxiety leads to a more stable condition in patients with bipolar disorder. As you can see, it definitely decreases in the presence of any anxiety disorder. And the one that you can see where it decreases the most is in social anxiety disorders. Suicide. As we know, bipolar disorder is the condition, the psychiatric condition with the highest mortality by suicide. And comorbidities increase the risk of suicide attempts. So here it is. When you have a comorbid anxiety disorder, that increases the suicidal thoughts. And it varies from specific anxiety disorder, but clearly in the presence of any anxiety disorder, you have more suicidality. There was an interesting debate going on 25 years ago. Some of you, especially those of my generation, might recall that fluoxetine Prozac was causing suicidality. And then they look at the data, and it didn't really, it wasn't clear. But then they further looked at the data. That's why you should not give up. And this is the data that of clinical trials held by in Lilly. And they did find that when patients had akathisia, that led to suicidality. So here's the question, or it's not surprising again that when you have a comorbid anxiety disorder, that leads to suicidality, which would be both attempts, thoughts, or actually death by suicide. So what are the predictors of having to attempt suicide? And in this case is in patients with a rapid cycling course. And as you can see, any comorbidity almost triples the risk of having an attempted suicide. So always keep an eye on your patients with bipolar disorder and comorbid anxiety disorder. This and effects on treatment. So this is quite interesting. So when there is a comorbid anxiety disorder, patients with bipolar disorder are less likely to receive a mood stabilizer. And of course, not everybody responds to a mood stabilizer. But clearly, if the patient doesn't receive it, that of course is a missed opportunity. So as you can see here, without anxiety disorder, patients get their medication, and with patients with anxiety disorder, then the chances of getting a mood stabilizer is of course lower. So this is, of course, is an example of misdiagnosis of treating just the anxiety disorder and not treating the mood disorder, the comorbid mood disorder. Now, let's look at, now let's focus on comorbid substance use disorder. What are and how does it affect course and outcome in patients with bipolar disorder? So an important question is, can you really diagnose substance use in the presence of affective disorders? Are you going to get that information? So this was a study conducted a number of years ago. and looking at the DSM, in this case actually 4. This is the key thing, that the significance comorbid substance use disorder was not associated with lower reliability of diagnosing this affective psychotic disorders. So there's evidence that you can diagnose this if you do the proper assessments. We've talked about misdiagnosis and mismedicated, and as you can see, correctly medicated, it's when you have no recent substance use disorder, as opposed to in the presence of comorbid use disorder. And it's actually more unmedicated than without substance use disorder, and also medicated wrongly. We gave the number of examples. Now, this is also related to response to treatment. Now, this finding is actually interesting. So, recent substance use disorder predicts non-response to lithium and valproate. As you can see, the odds ratio almost doubles. And there are other variables included in that regression model, more frequent in females. In other words, females, if they have a recent substance use disorder, will tend not to respond to mood stabilizers, in this case defined as lithium or valproate. Other effects of and we've mentioned some in terms of the presence, also earlier onset of major depression, and even in those patients called pseudo depression, and those are patients who have a first episode of depression, but later on have manic episodes. So that would be considered bipolar depression. And you have, again, more suicide attempts, more functional impairment, more medical comorbidities, and more likely to get into legal trouble. So it affects SUD, both alcohol and drug, major depression and bipolar disorder, as you can see, in different ways. Now, in patients with, again, recent substance use disorder, they actually, this is actually a puzzling finding. They tolerate lithium better than those without recent. There's something quite unique about these findings that I guess it talks about you never have the same findings in different studies. Now, this is a review that we did a number of years ago, and it's with compliance, substance use disorder. Again, the compliance of the mood stabilizers is actually worse with lithium than valproate. And some of the reasons is with lithium is the side effects that more, as you can see, that doesn't appear with valproate. So in patients who use substance use disorder and are being treated with these mood stabilizers, just be aware that increases the issue of non-compliance, especially of lithium compared to valproate. And what is the impact? This is a review that we did with our dear colleague Carlos Zarate. And some of the things that we found where we address is, well, the substance abuse cause bipolar disorder? That's unlikely. Most likely it's bidirectional, that it does contribute, but also having a bipolar disorder contributes to have substance use disorder. And the factors associated with in bipolar patients of having a mood disorder is those with an earlier onset. And many studies have shown that having an early onset of bipolar disorder predicts a poor outcome when you have family history of substance use. Not surprising, the presence of mixed mania. It's also very important to distinguish what is a primary and what is a secondary. And if you have two conditions, secondary would mean if it's related to the first condition. And this is a key point, that we can do preventive medicine in patients with bipolar disorder. And I'll give you the data later on when we look at the prevalence at onset and the prevalence. Well, we've already shown you the multiple episodes is over 60%. So why do we have such a high prevalence of substance use disorder and bipolar disorder? Well, risk factors certainly can be affected by the risk factors of bipolar disorder by the present substance use disorder. Can the mood disorder be secondary? Again, they're consistent. There might be a correlation, but not causal. This is a discussion that we always have with residents in the psych emergency service. Patient has bipolar disorder, took meth, and then we say, well, this is meth intoxication. The patient is going to get well. The patient doesn't get well. And that, of course, means that most likely the use of methamphetamine, highly prevalent here in New Mexico, is ubiquitous almost. You have many patients with bipolar, they take meth, they get sicker, they relapse into a manic episode. So an interesting point also about the substance use, can they cause mania? And the fact that when you have TBI, traumatic brain injury, you do have an increased risk of bipolar disorder episode of mania. So it certainly contributes. So the pathophysiology, well, the disturbance in the different neurotransmitter systems, and then in post-receptor and gene expression, there might be also something going on in both disorders. And in fact, an animal model that has been used in refractory mood disorder is the chronic administration in rodents. So there is something going on there. Now let's focus more on outcome now. This is the study that Coriel and others did a number of years ago, and they showed is long. It was actually longitudinal for 30 years, and it showed that patients with comorbid depression and substance use disorder, the risk of suicide increase. Again, presence of comorbidity worsens the outcome. So this is a preventive medicine. In this study that we've done in first episode, I'll be showing you the data in a moment. The prevalence of substance use disorder is about 17%. Okay, and we showed in the data from Americangas in population base, and for CAO in clinical base, treatment based studies, it was over 60%. So this means that comorbidity of bipolar disorder increases as the condition worsens. How can you do preventive medicine? Patient comes to you with bipolar disorder, say first episode, no presence of comorbid substance use disorder. Well, that is an example of doing preventive medicine. At UNM, as in a number of sites in the U.S., I think there's about 350 clinics of first episode. It's a collaborative model that you make this, that you plan treatment with the patient and their family, a lot of education. And this is one of the things that we focus, not only with the affective psychosis, but also with the non-affective psychosis at first episode. Remind them or letting them know that having bipolar disorder carries a risk of having substance use disorder in the future. So the importance of prevention, and of course, substance use disorder leads to a number of problems. So let's talk about treatment. It's many times it's sequential. Patient has bipolar disorder. Again, the majority don't have comorbid substance use disorder on outcomes, so the bipolar disorder is treated. And then, and I've seen this many times, my first episode patients, through time, then they start using drugs and then they get treatment elsewhere. So what is key is to have an integrated treatment center, being a patient center. We have in our clinics what we call medical homes That means I'll give you an example of a patient with or a clinic with schizophrenia. We bring primary care there because many patients, the only time they see an MD, many patients with psychotic conditions is when they see their psychiatrist. So let's bring the clinic there. Same thing with comorbid substance use disorder. We have this medical or patient-centered approach. We bring the experts in the addiction experts to our clinic, so they treat the highly prevalent number of patients with both conditions. Do it together. That is definitely the best treatment approach. So why is it integrated better? It's kind of obvious, but of course, when you have the patient treating the same two conditions or more than two conditions, we've mentioned the trio and the quartet, in the same place, it's more likely that they will follow care. It's also more likely that they'll pay attention. And it definitely, as Professor Soares mentioned, lifestyle needs to improve for all of us. Actually, this morning, for you in Greece, I know it's in the evening. For us here in New Mexico, it's early, so I had to debate: do I do my 5K run before or after my presentation? I decided to do it earlier just to have more energy. So I took my run to the Rio Grande and back to our home, which is 5K. So again, the message here is lifestyle is important for all of us, for our patients, and definitely for us as well. What study should we do? Well, it's obvious that cross-sectional studies are helpful, but what is more helpful is outcome studies, because it helps us understand the interaction and I'm focusing on obviously on comorbidities, the effects of having another condition, or how does a new condition affect the treatment or response to treatment. And also make sure, I'm going to mention again the importance of preventive medicine. Just going to finalize with some of the outcome studies that will show you the data. This is on their multiple episode patients, and they show alcoholism was definitely a predictor of relapse within 4 years. So this is we have the data to advise our patients to stay away from overuse of alcohol or use of other drugs. First hospitalization, it's medical comorbid disorder, also not low. So I remember this patient who had an autoimmune disorder and was treated with prednisone, and that precipitated the mania. So very, very frequent also comorbid mood disorders, and this is a first episode sample. It affects recurrence in first episode. So here's the data that I had mentioned to you before. This is baseline comorbidity at first episode, 18%. And as mentioned a number of times in multiple episode studies, is 60%. So there's the data. There was mentioned also by Professor Soares about functional outcomes. And functional outcomes, we follow this first episode sample. Lack of comorbidity increase the chances of having functional recovery. And also, as you can see, the comorbidities affect relapses, both symptomatic relapses as well as functional relapses. And this is what predicted a functional recovery. Here it is, not having a comorbid condition. This is the last thing I want to talk about is how can we explain like the misuse of treatment or stopping treatment. Actually, substance use disorder affects cognition. This is a review that was done, and 60% of the articles that this group of investigators looked at, there was presence of cognitive impairment. So that's another thing that we rule out. So let's summarize our presentation. Having comorbid conditions actually is a risk factor of poor prognosis. There's a number of interrelationships that we've mentioned. It is important to, when you have patients on maintenance treatment, that you also treat the comorbid condition, because it'll increase non-adherence. And as you can see, it varies from medication to medication. Actually, when you have anxiety disorder, sometimes we don't ask about alcohol, maybe because it's legal, but it does affect certainly the outcome of bipolar disorders. It is important to treat the substance use disorder, but appropriate treatment. Sometimes sending the patient to another clinic is not ideal. Education, especially in those with first episode, that's going to lead to non-adherence. And then, of course, cognition, if the cognition is affected, that will improve adherence and functioning and so on. So focus on both the primary and the secondary condition. So we'll stop now. This is a beautiful picture. This is the acequia next to the Rio Grande in Balloon Fiesta, October every year. Thank you, folks, for your attention. And I'll stop there.
Thank you very much for a very interesting presentation and a nice picture. And it's always very difficult to treat bipolar disorder and thinking of the comorbidities as well. This makes things much more difficult. Thank you very much. We are going to the next presentation, which is Neurobiology and Novel Treatments for Bipolar Disorder. Dr. Carlos Zarate will present. Dr. Zarate is investigator-in-chief of the experimental and therapeutic branch and on the section of neurobiology and treatment of mood disorders in National Institute of Mental Health, professor of psychiatry and behavioral sciences in George Washington University. Dr. Zarate.
Delighted to be here. Thank you so much for the invitation. What I will, I think this talk segues nicely with the previous talks in that we will cover basic concepts of neurobiology and rapid-acting antidepressant medications. This is my disclosure. I work for the intramural program at the NIMH, National Institute of Mental Health. Now, as already been summarized here, this is a brief summary of the outcome of our patients with bipolar disorder. Towards the right here, we see that even with standard treatments such as mood stabilizers alone or in placebo, we have very low rates of durable recovery. Towards the upper left here, we see the typical course of a patient with bipolar disorder. You start with a few episodes, lifetime, it increases, and then there's a constant illness later on. But towards the bottom left here, you see that the majority of the illness, a third of the time, is spent in depression. And so what has been proposed here incorrectly is that this is a disorder of preventing recurrences and maintenance treatment. However, there's a possibility of intervening maybe in another way to improve the course of the illness. Can we reduce the cumulative morbidity, that is the number of episodes and the length of the episodes over the duration of the lifetime, by shortening the duration of episodes with rapid-acting antidepressant agents? So if one has 9 or 100 episodes of depression, but you find an intervention that can work in a few hours or days at most, could you prevent the cumulative morbidity that was described earlier by our colleagues? That's one important concept. The other is that we talked a lot about symptoms, but we know that depression and bipolar disorder is much more than that. We see that it has systemic manifestations. We see increased rates of migraines, thyroid disease, HPA axis dysfunction. We've talked about immune systems dysfunction, where we have increases in IL-1, IL-6, TNF-alpha. We have effects on the cardiovascular system, where there's an increased risk of a death by heart disease just because you have depression. We have greater disturbances or alterations in the GI system. and greater rates of osteopenia. This is in addition to the effects we're well aware of on the brain in terms of impairment in sleep and in plasticity. So we should be looking at our treatments that have effects not only on moods but also on these different systems, and I'm going to provide some data to highlight that, especially with those of ketamine and their effects on biological indices of health. So we have our DSM criteria, which is a common language for describing psychopathology. We can see, though, the limitation here is this considerable overlap, as already described, for example, by Dr. Tohen. We see here that if you're trying to understand the etiology or pathophysiology of depression, are you really studying that, or that of the psychosis that goes with the panic or the substance use disorder? So our criteria was not established based on pathophysiology, but by group consensus. So some have proposed to deconstruct these illnesses into more simpler elements, into dimensions such as anhedonia, motoric levels, gather information at these different levels of units of biology, and in turn connect them with response. So for example, we know here that has been presented the linkage of improvement of mood or depressive symptoms with a treatment. But here, what we're proposing is to get closer to the etiology, pathophysiology by studying endophenotypes, something closer to the real causes of the illness. Here's an example with ketamine, for example, that works on the reward pathways and its relationship to its improvement in anhedonic symptoms. Now here, these are putative endophenotypes that have been proposed. We start with yellow, with blue, which are bipolar symptoms, dysregulation of motivation, reward, impulsivity, mood instability, suicidality has been covered today, disturbances in circadian rhythms, social behavior, mania, dysregulation of emotions. One dives into a endophenotype here, cognition and emotions, and what is reported are impairments in facial expression recognition, high reward sensitivity for mania, for example, impairments in attention executive function, and verbal memory deficits. And in red, you start getting at the image in the phenotypes, and you can see here how we start diving deeper in trying to get closer to the causes of our illness. And of course, factor in that there are genetic environmental illnesses such as genes involved in ankyrin 3, zinc finger, in neurodevelopment, stress and infections. Cytokine abnormalities have impact on this. So it's very important. So if you're going to uncover the causes of bipolar disorder, which is a very complex illness, that you take a very broad approach and study in multiple dimensions in terms of biology and symptoms. Now, these are critical areas of translational therapeutic research. Areas in need of study is that there are few or no drugs that have been developed specifically for bipolar disorder based on understanding of the underpinnings of the illness. We borrow medications for other purposes, antipsychotic drugs, and anti-epileptic. The other area of study is the lag of onset of antidepressants of weeks or months, drugs that do not work specifically in severe suicidal ideation, treatment with small effects, biomarkers that are predictive of sustained effects, and of course, a lack of translation from the bench to the bedside and bedside to the branch, back to the bench. These are the actions that we would take, which are contrary to what I just mentioned. Now, here has been proposed several different targets, kappa, the substance P, serotonergic, dopaminergic, glutamate, cholinergic, histaminergic. Some examples provided here on antagonism. You can reduce what's been reported in bipolar disorder, pro-inflammatory conditions or oxidative stress. Towards the right are receptor agonism compounds that might have effects where you would also decrease oxidative stress, increase neuroprotective factors such as BCL2, which has been reported with lithium and lamotrigine, or caspase-1 inhibitors. These are all proposed targets to pursue. Some of them are underway and have been reported positive. So the need to develop improved therapeutics for depression and treatment-resistant depression is summarized here. We know the severe disruption to personal, professional, social life, and of course the risk of suicidal behavior. The treatment options have already been nicely summarized and are highlighted here as 3 groups: psychosocial, pharmacological, neurostimulation, the limitation of our medications, specifically with the antidepressants, are the low remission rates, a 30 to 40% of treatment-resistant depression, and considerable lag of onset of antidepressant, anti-suicidal ideation effects. Here, this figure depicts a major depressive episode, which lasts about 9 months without treatment. When you initiate treatment with a standard mononergic-based antidepressant, you have a shift towards the left. You get better, but it takes 10 to 14 weeks for full response to take place, if it happens at all. This is unacceptable. We can do better by introducing next generation antidepressants, anti-suicidal ideation treatments that have an onset within hours or a few days at most. And we can do so with understanding better one prototype and others, such as ketamine, by identifying the cellular molecular targets. Now, our interest shifted to the glutamatergic system. There's considerable evidence in bipolar disorder of NMDA and AMPA receptors, which are key postsynaptic proteins involved in glutamate neurotransmission, that are altered on postmortem studies. Furthermore, we see that effective treatments such as lithium valproate, lamotrigine, and riluzole did tap into the glutamate neuroarchitecture and functioning. And you can see here examples. For example, lithium increases GLU1 expression, lithium alters glutamate reuptake, and also valproate has effects. So we decided in earnest to study different glutamatergic compounds. I'll summarize briefly, but here the prototype referred to is racemic ketamine, which is an NMDA receptor antagonist, has a very short half-life when administered intravenously, but has a number of side effects, psychological, dissociative, and abuse potential. But nevertheless, it is now approved one form of an intranasal as ketamine for treatment-resistant depression. Here we can see that it's binding within the NMDA receptor complex at the PCP site, which explains in part the dissociation and psychological disturbances with its use in a time-limited manner, which is the administration. Here, this was a proof of concept study whether administering a single intravenous dose would bring about rapid antidepressant efficacy. And the answer is yes. However, because of ethical reasons, we studied people who had failed 6 to 9 antidepressants. 50% had previous suicide attempts, and about 50 to 60% had failed electroconvulsive therapy. Here's depression scores. We can see single administration ketamine leads to rapid reductions in depressive symptoms. Towards the right are mononergic antidepressants. We're taking a pill every day for 8 weeks. 62% achieved response. We're seeing very comparable response rates within a matter of hours in individuals who have failed 6 to 7 previous treatments. We extended these studies into bipolar depression. Here, similar MADRS score, higher number, greater depression. One administration of ketamine intravenously led to rapid improvement within an hour, lasting a good part of the week. We went on to do a third study, a replication in bipolar depression, showing pretty much the same effects. Now, what is very noticeable from these 2 different studies is that the onset and offset of the antidepressant effects speaks to a biological process underlying the rapid response. And if we can understand this, we can perhaps develop better treatments. This is shown, this is a meta-analysis showing that the odds ratio of response is about 10 in 24 hours and about 8 at 1 week, considerably larger than our standard treatments. And this is another meta-analysis of studies done with ketamine showing a rapid anti-suicidal ideation effect within 1 day, lasting a good part of the week. which speaks to, this is quite important because it gives us the ability to get patients back to their families and to their treaters until the next treatment takes effect. Now, there are 4 major pharmacological classes with presumed rapid-acting antidepressant effects. The glutamatergic modulators I spoke of. Second group are the neurosteroids, GABAergic modulators, brexanolone, Sage 547, approved for postpartum depression. Opioids are being looked at, and then serotonergic hallucinogens. The prototype is psilocybin, a 5-HT2A agonist. Now, what happens is that they initiate at different receptors, opiates at opiate receptors, ketamine and glutamatergic receptors, and then psilocybin and 5-HT2A. But as they start going downstream, we starting to see an overlap in the plasticity cascades, and especially in network reconfiguration, we see increases in neurotrophins, spine turnover with neurogenesis, protein translation. So these 3 systems are linked but have different initial targets. And here's a summary of how these agents appear to be taking effect. Ketamine binds to NMDA receptors on GABAergic interneurons. You decrease GABA input, you produce an excitation of pyramidal cells, a glutamate increase, which leads to intracellular signaling cascade changes, spine growth, neurite growth, synaptogenesis. We see that mGluR2, 3, which are removed from the NMDA receptors, also produce this increase in glutamate, which is key because you might be able to avoid the side effects of ketamine because you're not blocking NMDA receptors. The son of ketamine, 2R6RHNK, also seems to increase glutamate and increase the spine and neurite growth. And the serotonergic hallucinogens do use the same plasticity cascade. So we can see that these different drugs have common downstream pathways. Now, this is where we were in 2000. We had a few drugs, ketamine, riluzole, memantine, and this is the scope of where things are today. We have drugs that bind to the NMDA receptors on GABAergic interneurons. You can regulate glutamate by blocking mGluR2, 3 receptors. Ketamine seems to have diverse effects on mGluR2. Also, the metabolite ketamine seems to activate AMPA receptors and produce this protein translation for spinogenesis. We can look at mGluR5 antagonists. One can activate AMPA receptors more directly to produce these plasticity changes. Some have argued that you can go to mTORC with NV5138, which does increase spines, at least in models. But the largest group of drugs, of course, are the NMDA receptor antagonists. They are listed here. One promising, one recent was REL-1017, which showed a rapid antidepressant effects within 4 days. And we have others listed here. One can go at the glycine site, which is a way of more fine-tuning the NMDA receptor complex. And then there are more subunit selective NR2B antagonists listed here, traxopradil or CERC301. These are, some of these are still in play. Now, we can go on to develop rapid-acting antidepressants, as I mentioned, based on a better understanding of the cellular molecular mechanisms of ketamine and other effective rapid-acting antidepressants using this strategy, as I mentioned, the RDoC, where it's multi-scale systems biology approach integrating a wide range of clinical behavioral technologies. All these techniques are administered in the same patient before, in their depressed suicidal state, and throughout the trial. So we get repeat measures to better understand the changes in biology and how it reflects the changes in symptoms. This is what is interesting of ketamine, racemic ketamine, is in addition, it seems to have effects in many of the conditions, as Dr. Tohen mentioned, which are important in comorbid conditions such as PTSD, OCD, anxiety disorders, and even substance abuse. Now, granted, these are some of them are single study, small sample size, but it is nevertheless intriguing. Other properties of ketamine seems to be improvements in biological indices of health. It's neuroprotective, has anti-inflammatory properties, improves bone markers and adipokines as well. One important pathway that is the intersection of the monoaminergic, glutamatergic, and immune response is the kynurenine pathway. Kynurenine is synthesized from tryptophan, which of course you understand is involved in serotonin synthesis. But here you can see there are two major pathways. Once kynurenine crosses the blood pathway, it can be activated. It can take a neurotoxic pathway that's involved in oxidative damage or free radical generation. The other pathways it shunts is by astrocytes, where you produce kynurenic acid, which is neuroprotective. And so what we see here in depression, the red arrows indicates that the pathway is shunted towards the neurotoxic pathway. So what you would want to do is shift the pathway to more of a neuroprotective pathway. And here with ketamine, in the green arrows, you see in many places it opposes the negative effects of depression. We see there's increases of kynurenic acid, which is important for neuroprotection, and decreases in quinolinic acid, which is associated with neurotoxicity. So even if these pathways are not involved in improvement in depressive symptoms, they may improve many of the comorbid conditions associated with depression. So another example is adipokines, which are cytokines or cell signaling proteins secreted by fatty tissue, very important in brain, liver, muscle, immune system. Now, what we noticed in some of our studies is that the greater your body mass index, the better the response to ketamine. We decided to look at it more systematically. There are three major adipokines. One is adiponectin, the second is leptin, resistant. And you can see here, for example, adiponectin is it's anti-inflammatory. You decrease insulin resistance, you decrease sympathetic tone, improve plasticity, and decrease pro-inflammatory effects. Whereas with leptin, you have mixed effects, and resistant is the bad guy. You actually increase insulin resistance, sympathetic tone, and pro-inflammatory effects. And so that would not be good in terms of systemic health. So we designed this study to look specifically at adipokines in unmedicated patients who received a single infusion of ketamine or placebo. We looked at adipokines at baseline and 230 minutes on day one for each treatment condition. And what you see here towards the left is a moderator of response. That baseline adiponectin predicted rapid antidepressant effects, a very strong relationship in these 80 patients. Towards the middle, we see effects of leptin and resistant after ketamine treatment. But when you break it down, looking at resistant, remember the bad guy, we see that it's knocked down specifically in bipolar patients, suggesting that even if it's not involved in the antidepressant effects of ketamine, might have pro-salutary effects on health. The other is bad to the bone or bone health that we see with depression, and even with our antidepressants such as SSRIs or osteopenia, decreases in bone health. We see greater disturbances in those with depression of osteopenia and osteoporosis. So here this graph summarizes factors involved in bone formation and resorption. Here we see that rank, which is the nuclear factor kappa B ligand, binds to its ligand, and that induces a decrease in bone density. So what you want to do is prevent it with OPG or other, which is a decoy receptor. So you want to shift it away to more bone formation rather than the resorption. And so here, what you look at are the desired outcomes. We either want to decrease rank-L or increase OPG and OPN. OPN or osteopontin is important in the scaffolding of the bone. And so when we look at that in a crossover unmedicated study, we looked at these bone markers at baseline, day 1 and day 3. to see what are the ketamine effects. And we see for the most part, this is all good to the bone. You see increases in the ratio of OPG in rank L. We see increases in OPN and the decreases in the rank L by itself. So these, again, another way of looking at indices of health. What was intriguing, how do we end up with new compounds in the glutamatergic system? We know that ketamine has rapid antidepressant effects, but it has dissociation and abuse potential. So what was intriguing when we were studying our patients on the inpatient unit, racemic ketamine has a very short half-life of a couple of hours. Dissociation lasts only 40 minutes. Yet why is the antidepressant effect lasting a week to 2 weeks? And so we wondered whether ketamine is actually a prodrug and are metabolites responsible for its effect. So through a systematic study, we looked at ketamine. When you administer it either in mice and humans, you obtain 24 metabolites within a matter of a few minutes. So we wondered, well, could some of them be an antidepressant and some of them be responsible for the side effects? If we could tease that out, maybe we could have a better drug. And we found that there is a group of metabolites called hydroxynorketamine or HNK metabolites that lasted 3 to 7 days, curiously around the same duration of the antidepressant effects. Ketamine. Through a series of studies with Todd Gould at the University of Maryland, Craig Thomas at NCATS, we identified a compound 2R6R HNK as a candidate drug to pursue. So this paper, this figure summarizes 20 experiments in this paper. So this is what happens when you inject ketamine, racemic, into mice. You obtain 24 metabolites in a matter of minutes. So how do you figure out what is responsible for antidepressant effects and for side effects for addiction? Here I mentioned that some of the metabolites last 3 to 7 days, the hydroxynorketamine. So when you take a racemic ketamine and by a chemical process you strengthen carbon-6, you produce dideutyrium ketamine. When you do so, you eliminate or reduce the metabolism of ketamine. So in essence, you have ketamine without metabolites, or D2 ketamine. When you inject it in mice, you no longer have the rapid antidepressant effects, but you still have the side effects and addiction properties. So when we take our candidate molecule 2R6R HNK, we inject it in mice, we find it does not block the NMDA receptor, but in fact it has effects on mGluR2, another receptor that is involved in glutamate release, as I mentioned. It doesn't produce dissociative side effects, there's no abuse potential, and it activates AMPA receptors. And so in essence, we separated the wheat from the chaff with these series of experiments. We have now taken our compound and are moving it forward in terms of drug discovery and development. Very briefly, one here is that when you administer 2R6R HNK, you produce this increase in glutamate release, activates AMPA receptor. When you take an inhibitor, you no longer have that increase in glutamate. Here we see the extracellular levels of glutamate, the glutamate burst when you give ketamine. If you pre-treat with an agonist at mGluR2, you no longer have that increase. So we have two compounds that are under study right now. We've completed a phase 1 study, and now we are doing a phase 2 with an mGluR2 antagonist, TS161, which preclinically mimics many of the properties of ketamine. The second study is the son of ketamine, hydroxynorketamine, which is an NMDA receptor independent. It also overlaps with many of the properties of ketamine, but without its side effects or abuse potential. We have completed, we started the multiple ascending dose, and we should start early next year. So to summarize, ketamine produces rapid pan-therapeutic effects or broad therapeutics on depression, suicide, and anhedonia. Its NMDA receptor does not appear to be a primary mechanism in our hands. Glutamatergic modulators are still being explored for TRD. Metabolism of racemic ketamine to 2R6R-HNK seems to be essential for its antidepressant effects, and it appears to be independent of NMDA receptor inhibition, and AMPA receptor activation appears to be key for the acute and continued antidepressant effects of ketamine. Thank you for your attention.
Thank you very much.
I think there are some questions.
I didn't get any questions. Kostas, did you?
There is one.
Okay. Is there any data on whether comorbidities differ along the course of the disease? Dr. Ioannou, Adelina Ioannou is asking the question. So maybe Professor Tohen.
Until Mauricio returns, I could say that we did some research on how this comorbidity works, how it coexists, and it seems that at least some of these comorbidities are transnosological. Okay, we knew that. For example, anxiety. But there is some chance. There is an increase existence of specific comorbid disorders, for example, migraine, because there is a shared psychopathological mechanism, or there is a vulnerability, a specific vulnerability. But still, we don't really know, and we don't really know. Mauricio is back. We don't really know how, by changing the stage of the disorder, by advancing the stages, how this also develops. I think, I'm not sure whether Mauricio will agree, but I think that by advancing the stages, all mental disorders tend to be somehow similar in a way. They are more alike than different. I'm not sure whether Jair or Mauricio agrees with that, but it's a clinical intuition.
I'll make a comment, but Mr. Chairman, can you repeat the question again, the original question?
I think that the question was answered later on in your talk. That's what.
The question was whether the advancement of the disease affects the comorbidity.
Actually, that's a very interesting question. And during the presentation, we talked about studies that need to be done. And actually, that is a great study question. What I can mention is that with the data that is available clearly, as conditions, as time goes by, there's more comorbidity. So it was interesting the way that Carlos started his presentation, meaning that it's not really just relapse, it's time of being ill. And in other words, really looking longitudinally as opposed to cross-sectional, and that by shortening the episodes. So I think that there might be something there, that if you shorten the episode and you decrease the number of episodes, I wouldn't be surprised if that overall decreases the presence of comorbid disorders. Now, that's of course when you have the bipolar disorder appearing first. When you have the comorbid disorder, let's say the substance use disorder, that might be different. But what I would predict is that even if the substance use disorder starts first, bipolar disorder will not only worsen the patient's functioning, but it also will worsen, for obvious reasons, the severity of the substance use disorder. So it's an interesting question that deserves more study and actually appropriate treatments.
So,
Back to you, Mr.
Well, I'd just like to add briefly to what Professor Fountoulakis said. Well, so there is data showing that many of these major psychiatric illnesses, they will put people at a high risk for dementia later in life. So I think it's probably, to the extent that some of these will continue to progress and cause more damage to the brain, I can see, why the symptoms might become more alike as people go through that. But like bipolar disorder, chronic depression, schizophrenia, these things seem to be risk factors for dementia later in life as well.
Okay, thank you. Are there any other questions?
I would like to ask Carlos. Carlos, are you here?
Yes. Oh, my camera's not on?
Yes, very okay.
It is on, yes.
These substances that act on the serotonin system, like psilocybin, do you think they really have a future? I mean, isn't the serotonin system exhausted in terms of therapeutic goals and studies?
Yeah, so that's interesting that the 5-HT2A agonist, which is presumed to be the primary mechanism, we have studied, 30, 40, 50 years serotonergic mechanism, and why would we have not seen it? And many of our treatments do have the same effects, right, already. But, it's not really clear in my mind. One is there is evidence of antidepressant effects with the psychedelics, but we need more evidence because there are issues with, similar to what happened with ketamine, the blinding. Initial studies did suggest very rapid onset lasting 6 months. More recent studies suggest, well, maybe it's not that rapid. The recent data suggests maybe 3 weeks. And some study, that was published in New England Journal suggested, well, maybe comparable to, sertraline, I believe it was, or citalopram, I believe. So I think more studies are needed. It's not clear to me that 5-HT2A is the primary mechanism. What people are arguing is that at least at the preclinical level, you see increases in spinogenesis, neurogenesis, overlap with many of the mechanisms of ketamine, and thus it should be rapid like ketamine. But keep in mind, we've had several compounds, GLIX13, scopolamine, that showed many of the same checkboxes as ketamine, but didn't pan out to be rapid, and many NMDA antagonists. So it's going to probably be more complex. Look at the more effective treatments such as ECT and ketamine, and if you want to say scopolamine, they seem to have many seem to have a rich pharmacology and do many things. Even clozapine for psychosis. You wonder whether going to single target is really going to be the main treatment here, where you need to have a diversity of effects. So I think it's too soon to know whether they're going to be effective, but the studies look promising and encouraging for now. We're going to have to, see. One of the major issues, of course, what we have is that the assisted therapy, where we still don't know if the drug alone does its effect. And all the biology, human and preclinical, is done without the therapist, right? You don't do imaging with the therapist. So then you wonder whether what you find in terms of imaging really applies because you don't have the therapist there. Those are things that need to be looked at, but I think it's a very encouraging, promising area. I don't think we know yet if 5-HT2A will do it.
Mm-hmm.
Just a comment on what Carlos said. A few years ago, we tried with John Kelso to derive a model on bipolar depression. And one of the problems was that there is no adequate literature on the pharmacodynamics of most agents currently used and approved. So we don't really know which receptors are affected. We don't really know exactly and reliably the KIs or the other pharmacodynamic properties. And there are some agents very well studied. For example, olanzapine, Mauricio, it's very well studied, but ziprasidone is not. Aripiprazole is not really. Lamotrigine is, we know, almost nothing. So we can, and what we know is rat receptors, rat neurobiology. So it's very difficult to extrapolate from medication to diseases because we don't know the intermediate, what links them.
May I have a question also, Kostas? You mentioned the treatment with lithium, and when we are talking about women in reproductive age, and we have to add something, what about we have a black box for valproic acid? What about lithium at this period? We also have problems there, aren't we?
But the first question I would ask is, do neurologists have black box for valproate concerning epilepsy? I'm not sure. I think not. I'm not sure.
No.
Maybe. So what I mean is that maybe this black box is too much. But anyway, theoretically, if we are not discussing about gestation, but we are discussing about females themselves in reproductive age, I don't think there is any problem with any of the others. Of course, taking into consideration that there could be a prolactin increase, amenorrhea, and all these issues, but I don't see any other problem. But if we enter gestation period, then that's quite different story.
Mm-hmm. But if we have to add one of two, lithium or valproic,
well, I would focus on the clinical aspects of the disease, and if lithium would be the most appropriate, I would add lithium, and if valproate, I would add valproate. So not the gender and the age, the reproductive age, but the indication, the clinical indication. But I would like to hear what the others have to say on this. It's very interesting.
If I may add, the postpartum period is a high risk. In fact, it is the riskiest time of an individual, the postpartum period. So the question, should we add a mood stabilizer? It's an appropriate question. Now, on the other hand, if you're treating, say, bipolar patients who's been unmedicated and then while she's pregnant, she becomes manic, lithium and valproate are not good choices. As we know, they don't treat mania well, they take a long time. The safest one appears to be quetiapine, because it is the one that has a lower chances of reaching the product. So, so again, the question would be, what are you treating? Acute mania, I would not use lithium or valproate. On the other hand, if you're appropriately using preventive medicine in getting a patient started on a medication to prevent the very risky postpartum, why not go with the mood stabilizer? Is a term that was, I guess, stolen by lithium and valproate. But if they're good mood stabilizers, it would be actually atypical. Quetiapine would be an example. Of course, it has other problems with the weight gain and so on. So that would be what I would do clinically based on the information that I have. I'll be interested on what Jair and Carlos have about treatment of the pregnant patient.
The question was not the
pregnant.
I understand.
For the reproductive period phase.
Yeah. So I don't think there is a whole lot of data, to show that that prophylaxis right after the delivery. I suspect, like Mauricio, that it would help, makes sense, but probably, you would not want to encourage that patient to continue breastfeeding because, these medications are going to be excreted in the milk. that's an area that develops very fast. So usually what I do, I consult with my colleagues who are in perinatal psychiatry, because they will know the latest for how much of each particular medication is actually excreted in breast milk. I mean, based on studies that continue to come out. But if this was my patient, I would probably, if I wanted to do prophylaxis, again, if this is someone who had been very unstable before, where, when you balance so you're going to probably have to stop breastfeed or not breastfeed at all, but this may prevent you from getting into, and let it to the patient, to decide, since I don't think there is much evidence there to guide us.
Getting back to your point, Kostas, so using valproate and Dr. Dioganis, using valproate in reproductive age. So in the US, we do have the black box. Do you have that in the European Union? It sounds like you do.
We have a black box, yes.
Yeah. Well, the thing is that unfortunately or fortunately, we do practice defensive medicine. So I stay away from valproate in my female patients in reproductive age, because of course the polycystic ovaries risk, the risk is there. Sometimes, of course, patients develop that in the absence of valproate, but just the fact that you are prescribing something that has a known risk. A key thing would be, of course, the decision should be made by the patient. I think the problem would be if you don't inform the patient that using valproate in reproductive age has consequences. So the patient should decide. My role is to give the patient the information. That's how I would deal with it.
Mm-hmm. Okay, thank you. Are there any other questions or comments? If not, I have to thank you all.
A comment. Thank you, Kostas and Dr. Dioganis, for putting this together. It's always a good opportunity to see good friends on a Saturday morning. So thank you for putting this together. Saturday evening for you, I know.
Thank you very much. Yes, it's evening for us.
Thank you so much.
Okay.
Bye-bye.
Bye.
Bye-bye. Thank
See you soon. Take care.